So good afternoon and welcome to the 10th webinar in the series of webinars by Patient Support Group of ISBMT. So the topic of today's webinar is mucositis, that is oral ulcers, which is, I think, one of the most common but transient complication which our patients face during bone marrow transplant. So before going ahead with our first session, I would just briefly introduce the patient support group members. We are very privileged to be mentored by Dr. Revati ma'am, Dr. Tapan Saikia sir, and Dr. Shashikant Apte. And as members of patient support group, apart from me, we are also joined by Dr. Venkatesh from Aurangabad, who is a hematologist, Miss Ria, who is psycho-oncologist at Narayana Health Bangalore, and Miss Suman, who is nursing in charge in the BMT unit at Tata Memorial Hospital, Mumbai. So it's a pleasure to introduce our esteemed speaker for today's session, Colonel Dr. Sanjeevan Sharma sir. Sir is professor and head of the department at the Department of Hematology in Army Hospital RNR in New Delhi. Over to you, sir.
Thank you, Dr. Silky. So while I'm in the process of sharing my slides, I think you touched upon a very pertinent point in your introduction, and that is when you said that it is, though transient, but a very common complication which the patients of our transplant face. And Neerav, are the slides visible?
Yes, sir. Good to go.
Fine. Yeah, so this is the first time I'll be. So firstly, thanks very much for the team ISBMT, the patient support group, and it's a wonderful initiative. For me, it's the first time attending a session here. And since it is addressed towards patients and the people who are the most important people, that is the people who take care of our patients while they're going through the transplant. So for them, understanding mucositis is the key, because whatever be the complication, whether it is a transient complication or a permanent complication, empowerment comes by knowledge. And once our patient support, the patients and their caretakers, they understand what is mucositis, I think though howsoever painful it may be easy to endure. So before we talk of mucositis, I think we need our patients to understand these are although medical sounding words, but they are very simple English terminology. So what is mucosa? So I would say mucosa is like it's that covering or the lining. So if I am staying in a very fantastic, howsoever costly house or a building I may be staying in, the final finish comes that coating of that, the best, whether it's an Asian paint or an acrylic paint, which is the coating which is given into the by walls. If I have a furniture, the coating which is given onto that. So it is that covering which makes everything. And mucosa, unlike a acrylic or a wooden, it's a living thing. Mucosa is very much a living membrane of our. In fact, some people have estimated that it is one of the largest organ if we can calculate all the mucosa which lines every part of a human body internally. So our entire GI tract, the respiratory mucosa, the GU mucosa. So it is that covering which lines our entire gastrointestinal tract, and we are talking of the mucosa today of the GI, the esophagus, the stomach, and the intestines. And what makes mucosa very special is it's got a very rapid cell turnover. It's not that mucosa which I am having today or any one of us is having today probably came just a few days ago, maybe just 3-4 days ago. Because 3-4 days ago, there was a different cell altogether which has been born off. It has been, discarded, and are now a new lining of cell. And this is going to remain another for maybe for 3, 4, 5 days. 5 days later, it will be a new set of cells which would be lining. So it's got a very rapid turnover, and that is what it protects us from. By refreshing it so quickly, it clears out all the abrasive, the chemicals, the pathogens, the various bacteria, their toxins which keep on invading us. it rapidly clears. And whenever we have an injury, inadvertent injuries, we've all noticed it, like even a small nick which we give maybe while brushing our teeth or something, within 2 days it is healed. No other part of the body heals so rapidly as the way our oral injuries heal. So the second concept is, first is what is mucosa and its rapid turnover. How does any chemotherapy or radiotherapy work? Whether we are using it as a part of our transplant conditioning regime, that it selectively kills rapidly dividing cells and it spares the non-dividing cells. So our body, which is a mixture of both the kinds of cells. So we've got cells in our, say, muscles, the bones, the brain, the heart, the lung. They are relatively non-dividing. Once we are born and we have attained a particular slice, our muscle cells, they don't divide. The brain cells don't divide. In fact, the brain cells don't divide after birth. Whatever we are born with, they remain with us for the rest of our lives. Kidney cells don't divide. So there are these non-dividing cells. At the same time, there are some cells which are rapidly dividing. Which are these? The most rapidly dividing cell is the bone marrow cells. That is which gives us our RBCs, WBCs, and our platelets. The second rapidly dividing cells are the mucosa. As we said, very rapidly they are turned over. Our hair follicles, and I'm sure all of us know, that's why our hair keep on growing, because the follicles are continuously dividing. We take a haircut and it grows within no time to that same length. Our skin is again not a simple tissue which has just lined us like a uh, covering from outside. It is again being turned over, although less rapidly as compared to mucosa. Maybe a skin turnover takes up to between 20 to 25 days, unlike a mucosa which turns over within a matter of 3 to 5 days. And of course, the gametes, the ova in females and the sperms in males. And if we see all our chemotherapy and radiotherapy, specifically, all side effects are related to damage of one of these things. So we have all understood when the bone marrow cells are are damaged with chemotherapy, we see all the effects: anemia, thrombocytopenia, and neutropenia. Mucositis is what we are discussing today. We have all understood why all our cancer patients, they lose their hair. There are a lot of skin changes, and of course, there are the issues of infertility. That is for other. So the basic concept is the same. Rapidly dividing cells will be damaged by chemo and the radiotherapy. So coming for today's discussion, mucositis, it's the painful inflammation of that rapidly dividing mucosa. Very common side effect after cancer therapy, including either a radio or a chemotherapy, whatever we give for conditioning. Although it's temporary and heals on its own, but during that phase when our counts are low, it can be extremely painful and it has its own risks, we'll come to. So this is two big white patches. Please look at the picture in the surrounding. The entire, as if this healthy red pink mucosa is denuded. Even the gums you see are hyperemic. That the part of the gums which are in between the teeth. This is how mucositis looks like. And what it does, it damages the existing cells in mucosa. At the same time, it impairs the ability of these mucosal cells to replicate and heal. That is what our conditioning of transplant does. And because that gut, which normally requires a protective barrier, which is given by the mucosa, now that is exposed to the irritation from all the chemicals which we throw at our mucosa, whether it is in form of food, the medicines, the masala in our food, and everyday function, whatever we do, a simple, cleaning our mouth, oral hygiene, all these things. So that mucosa, which is now being denuded, it gets irritated. And at the same time, what mucosa was protecting us against invasion from the various, especially the bacteria and the fungi. Now, these bacteria and fungal spores have got a free access. So it's like a walk-in situation for them. What mucosa was stopping them, now these bacteria are free to enter our the bloodstreams. So, but how does it manifest? If it's a oral mucosa, that is if it's only because that's the commonest what we see in our patient, which affects the mouth and the inner lining of our cheeks, which is also known as the buccal mucosa. These mucous membranes are particularly sensitive to pain, and it takes place inside the mouth. It becomes red, swollen, raw, painful. We saw that picture of mouth sores. Sometimes they may get infected and they may become white with patches of pus. small little superficial pus patches. Whereas if it affects the mucosa of our stomach or the intestines, it will manifest as pain, because the same thing what is happening inside the mouth is happening inside our stomach and intestines. So it will manifest as nausea. Our patient immediately loses appetite, and diarrhea. If it affects the lower intestines, the whether it is the colon or the jejunum or the other part of small intestine, then the patient gets diarrhea. Sometimes a very painful diarrhea, sometimes blood with blood stained diarrhea, because now the colon mucosa has also been involved. So this is how, if this is again a picture of the upper part, which we call it as the soft palate. The posterior part, you can appreciate the tongue down below. And once we ask our patients to open the mouth and we shine a torch every day into a patient's mouth, this is what we are trying to look for. How bad is the mucosa of the palate damaged? So now WHO has given us a grading, because we need to assess our patients on a daily basis to see whether it is improving or whether it is further deteriorating. So grade 0, 1, 2, 3, 4. So as we can see, as it goes down, so initially we may see people with all these soreness, but they're still able to eat or drink. So we call it typically as grade 1. So there may be a little bit of pain, but our patients are continuing to have their food and drinks. At grade 2, our patients will be able to take semi-solid, maybe liquid kind of diet, but will not be able to chew anything. Yes. And by the time we come to, if you descriptions are there, grade 3, at grade 4, the patient will not be able to swallow even liquids. So as we say, alimentation is not possible at all. So if the next question would be, how many of our patients get mucositis? So I'll say almost 80. Various studies have said, some people have said 67, 70, but our experience has been that 80 to 100% of the patients who get whole body irradiation or myeloablative therapy for stem cell transplantation will get at least a grade 1 mucositis. And it is more frequent when we use particularly high dose melphalan, something like we use in a myeloma transplant, 200 milligrams per meter square. We use a myeloablative dose of total body irradiation or high doses of busulfan. And although it's there with other drugs also, like fludarabine, cyclophosphamide, triosulfan, thiotepa, but lesser as compared to when we use these conditioning. And then there are these certain set of patients who are more likely to get, even with lower doses, is people, if we have got an adult patient who's been a smoker, or who's been chewing tobacco, or he's been indulging too much in alcohol, they're more likely to get mucositis. Of course, if our patient is dehydrated, which we'll make sure that they are not dehydrated if they are under a PMT, but inherently, because of poor alimentation or poor nutrition, because they've been on prolonged chemotherapy, they're already suffering with inherent protein deficiency. So by the time he's come to us for transplant with multiple chemotherapy, sometimes we have children who are absolutely emaciated. They've got a protein energy malnutrition, but we have to take them up for transplant because the disease may relapse. So these are the kind of patients who will more likely to have mucositis. People who are, as we said, emaciated, very low BMI less than 18. People who have elderly people sometimes say come for a myeloma or lymphoma transplants with dental implants or dentures. They have a pre-existing gum disease, kidney disease, or they are diabetics. So this is what typically happens. You can see that pinkish purplish thing is the mucosa. Then it got covered with this. What is shown is a kind of a microscopic cut section representation part. So you can see these organisms with tail. That there are all these bacteria which are kind to invade, and they have formed a slime over top of them, which has covered it from a top, and that is what is seen as a white patch. But inside this white patch, these bacteria are thriving. They're trying to enter our bloodstream through the submucosa. So our patients with oral mucositis will have, as we said, red, shiny, swollen gums, a dry mouth. They'll have a very thick and uncomfortable saliva, mouth ulcers. As we saw, you will be seeing white, painful patches, and they may sometimes ooze out pus. Sometimes the mucositis patches become so extensive that our patient can barely talk. Uh, Eating, of course, is the first thing which is affected. And in the grade 4 GVHD, even swallowing liquids become a challenge because the posterior part of our throat is equally affected. And of course, when it is sometimes very extensive grade 4 mucositis, we may even see bleeding. So we may see, bleeding from a mouth, they may spit blood while passing stools, we may see fresh blood in their stools, abdominal pain, nausea, vomiting, diarrhea, and as just mentioned, blood or mucus in stool. And sometimes, even if there are no blood or mucus in stools, the bowel movements, just the passage of stools on a daily basis, it becomes a painful issue for our patients. What complications mucositis can cause? Dr. Silky mentioned right in the beginning, it's temporary. Yes, it is transient. Every patient will mucositis will eventually come out of it. That is one thing good. But during this phase, they may go, if it is really bad mucositis, then nutrition may suffer. And that's why it's important that as many as 70% of our patients may require TPN if they have a bad mucositis. Diarrhea, if it's sometimes prolonged and watery diarrhea, we may land up with a lot of electrolyte, especially potassium and magnesium imbalance. And of course, infection. What are natural barrier mucosa is there? Mucositis has uh, caused open sores, and we are inviting bacteria to enter our bloodstream. So, especially people who have neutropenia because of mucositis, they can really go into a very bad sepsis or septicemia when we require high doses of antibiotics and sometimes very bad supportive care. Treatment is basically prevention to the, as we said, almost 80% will get it. So, sometimes before giving chemotherapy, like during Melflan, now it is standard protocol. I think all the nursing staff in all our BMT units, when we had this discussion in the nursing team during, I think ice chips is something which all of us are using. So that to some extent prevents the toxicity and the mucositis caused by high dose Melflan. So while infusing Melflan, we are making people have ice chips, and a very good innovation with some of our colleagues did was, especially for children who are, not very enthusiastic about ice chips, but they were very happy to have ice cream. So they had ice cream while their Melflan infusion was going on, especially lymphomas during their beams. Topical agents, like we use a whole lot of topical agents, whether it is a calcium phosphate rinse, cafesol, it comes, there are locks, viscous, various brands are there, but our nursing team prepares a beautiful thing, what they call it is a magic paint, which topical agents which we apply sometimes in anticipation, even before the mucositis has actually set in, to try and prevent it. And once it has set in, then pain relief is the answer. So topical pain relief by, say, some hexidine or choline based topical, and if it is not sufficing, then even systemic. So injectable pain relief, whether we use tramadol or we use morphine, depending on the level of seizure. That is something which we decide on bedside. Nutrition, as we said, it's a very important part. If our patient is having mucositis, we shouldn't allow the nutrition to suffer. So I think we should have a very low threshold of starting TPN. We know just a matter of 10 days, 15 days. And as the uh, counts will come back, the mucositis will heal. The person will start taking natural diet. But we shouldn't allow him to go into an undernutrition stage during these 10 or 14 days. Growth factors, yes. So there is a keratinocyte growth factor, palifermin, not readily available in India, which what GCSF does to the marrow, that when the neutrophils are low, we give GCSF and increase the counts. Palifermin. So I'll just show you this little randomized control trial. So it's for uh, ease of this thing, it's a colored bar. So you can see the various grades of mucosa have been divided into colors of the blue and yellow and the gray colored boxes. So SCPR is what we commonly use. So it was a randomized trial in 148 patients. One half of them got supersaturated calcium phosphate rinse and the other half got palifermin. That is the keratinocyte growth factor, which we were just alluding to. So if you see the SCPR group, the bar on the left, almost all the patients had a grade 3 or a grade 4 mucositis. Whereas in the palifermin group, not everybody got. So around 50% of them, they also got grade 3 and grade 4, but others escaped with grade 1, 2, or 0 mucus. So you can see almost, 15% of them didn't get any mucositis at all, grade 0, no mucositis. And those who did get grade 3 or 4, they recovered within 2 to 3 days. So this is the advantage of using this growth factor known as palifermin. So this is what I had to say, and if I'm sure there'll be question and answers at the end of it, which we'll all address. I'll just stop sharing. Yeah.
So, thank you so much, sir, for that very comprehensive and very easy to understand talk. I think our audience must have understood most of it, and it will make it easy for them to understand the panel as well, the panel discussion. So we will move ahead with the second session, and I would like to introduce the moderator of this panel discussion session today. We have Mr. Neeraj Trivedi with us. He's founder and director of BMT Support Foundation from Pune. Over to you, Mr. Neeraj, for the panel.
And yeah, so I'd like to introduce the panelists who are going to be a part of this panel discussion. We have Dr. Shruti Kakar, who's a professor in pediatrics and a consultant hematologist in stem cell transplant from CMC Ludhiana. We have Ms. Meeta Roy Chowdhury, who is the principal nursing officer and assistant professor at Narayana Health, Kolkata. And thank you so much. We also have two more panelists here. Of course, Colonel Dr. Sanjeevan Sharma, who just made an extraordinary presentation of a very simple, lucid, and easy to understand topic. So really, thank you so much for that. And we also have Ms. Suman Kubal, who is nursing in charge at BMT unit at Tract Tata Memorial, Mumbai. So thank you all the panelists for joining in today. And I think we have a set of questions that I think we will go through. So I think in a sequence, we are able to answer all the queries. Yeah, and just for the benefit of the audience, these were queries raised by patients over a period of time, which were consolidated, and we kind of circulated it to ISBMT. So I think we will go through them in detail. Yeah, so first question, Ms. Meeta, I think this is for you. What is mucositis, like in a very easy to understand patient language?
Good afternoon to you all. Thank you so much, Mr. Trivedi, and my sincere thanks to ISBMT organizer for this opportunity. I will take the question. Already Dr. Sanjeevan has described everything, but I will just go with the question that is mucositis. By definition, it is the breakdown of mucosal integrity of oropharyngeal and GI tract, which could be extended up to anal region. And involvement of the buccal mucosa is the oral mucositis, whereas GI tract is the GI mucositis. It's a debilitating clinical scenario which occurs followed by high-dose chemotherapy with or without radiation, and with the mini methotrexate, what we use as GVHD prophylaxis in hematopoietic stem cell transplantation. It's characterized by, as I already said, painful ulceration, erythema. There is swelling, and this patient may find difficulty in swallowing the food, difficulty in talking. There could be local bleeding or maybe GI episode of GI bleeding, nausea, vomiting, and diarrhea. Incidences usually for the autologous where we are using high-dose melphalan as well as beam protocol we have seen, or for the small children where they're using Bumel. That's the most toxic protocol what I have ever seen. So such cases, and also allogenic transplant where we are using MAC, myeloablative conditioning with or without radiation. Incidence is around 80 to 90%, and with radiation, definitely 100% mucositis is ensured. Thank you.
Yeah, thank you so much, Ms. Meeta. We can go ahead. Yeah, so Dr. Shruti, I think one of the things that patients always want to understand is, like, can I really be prepared for anything as to when it comes and not it comes? So I think it'll be good for them to understand when might it start during the phase of BMT, and how long is it likely to last? in terms of process.
First of all, thank you, Dr. Neeraj, for inviting me to be a part of this activity. Just for making things simpler for the patients to understand, I've put a cartoon here. When somebody is receiving a bone marrow or hematopoietic stem cell transplant, there are different phases. One being conditioning, when the high-dose chemotherapy is being given, and conditioning may last, for like our melphalan for autologous myelomas, and then for lymphomas, it could be as long as 4 to 5 days when we are giving beam, and for thals, it may be a little longer, right? So that phase when we are giving, chemotherapy to eliminate the hematopoietic stem cells for the recipient, that is called conditioning. Then there is a period when the reinfusion, that's the day 0, when the reinfusion is done. And following that, we go into the patient goes into a neutropenic phase. Now, it is during this phase, by approximately day 5 to day 6, that the mucositis starts appearing. Mucositis, as Dr. Sanjeevan says, they are very rapidly dividing cells, right? So if, the neutrophil count starts coming up or the recovery starts, it can start healing somewhere between 5 to 7 days. But in cases of a myeloablative transplant and an allogenic transplant, it can take up to 2 weeks to completely recover. So on an average, we expect it to start somewhere around day 5, and it would last for a week to 2 weeks, depending on the overall condition of the patient, what chemotherapy the patient has received, what radiation they have received, right? And once the engraftment occurs, that means the cell recovery has started. We can also think, expect the mucositis to start healing. So I think that would be clear with the help of the cartoon. Thank you.
Absolutely. Fantastic. Thank you so much. Yeah, we can move ahead. How early and, like, does a caregiver, like, what are the signs that he has to look out for? Because not our caregivers kind of know what to look out for and stuff like that. But I think being in the BMT unit, there is an inherent advantage where doctors and nurses kind of look at you. So this question is for Miss Suman. What signs and symptoms do you look for in a patient when you kind of look at him in the BMT unit with mucositis or like having mucositis?
Hello.
Yes, ma'am.
Good afternoon all, and thank you for the question. As mucositis not only damage the existing cells in your mucosa, but also that damage the ability to replicate and heal themselves. So mucosa get exposed to the irritation from their daily activities. Oral mucositis makes inside or mouth inflamed, and gastrointestinal mucosa also manifests the abdominal pain, nausea, and diarrhea. So sign and symptoms, I have the next slide. Please, can you please? Neerav? So you can see the sign and symptoms: dry mouth, then shiny swollen gums are there, white soft patches will be there on the tongue or gingiva, painful sore in the mouth will be there, bad breath because of the wound or ulcers are there, then pain or mild burning sensation will be happen while eating, and difficulty in swallowing, and the speaking will be there. In extent mucositis, blood in the mouth can be experienced. So it can be hard to manage mucositis and to determine how bad the case is, because each person will have different signs. So the WHO has organized a oral toxicity scale. That one, many grading system is used to stage the severity of mucositis. As Dr. Sanjeevan has also explained that slide. Next slide, please. So here is the WHO oral toxicity scale. Grade 1, you can see the soreness or plus or minus erythema. Grade 2, erythema with ulcer. Patient can swallow solid food. And grade 3, ulcers will be extensive erythema. With patient cannot swallow food and liquid diet he can take. And grade 4, mucositis level extended and alimentation is not possible, where patient cannot swallow his own saliva also. So frequent oral examination needs to be done. Okay, thank you.
Yeah, and just on an extended note, I have this question for you. I think Dr. Sanjeevan also mentioned about maybe there could be blood in the stools. So, like do
so
the
if
caregiver has to try and see if there is any blood in the stool or something? Would that be a good practice?
yes, so whenever patient pass stool, we check that stools
Okay.
and we can identify. Patient may have diarrhea because the GI tract is involved in that. So the diarrhea can, bloody diarrhea can be happening there.
Okay. And just for patients' reference, you've used the word erythema. Can you just explain? Is it swelling or is it something else?
So in first, they may feel something in the mouth, in where they can swallow food.
Yeah.
And after that, they can have erythema or white patches will be there. So
Right.
that
So
we can,
erythema is a Greek word.
yes,
Eri means red.
Okay.
Thema means covering.
Okay.
right.
So yeah, it's a standard Greek and Latin.
Absolutely. Thank you so much. Thank you. Yeah, I think we can move ahead.
Inflammatory situation, it happens.
Yeah, I think this is a question for Colonel Dr. Sanjeevan. I think this is to you, which you explained. Is there a specific chemotherapy conditioning or regimen? I think you spoke about
Yeah,
melphalan.
yes, yeah. So
But anything
definitely.
else that you would like to add apart from the slides that you showed?
So after all, from the patient point of view, yes, we warn them in advance. Ms. Suban just rightly mentioned that sometimes when we are going for a myeloablative conditioning, we know that a high dose melphalan or a combination of busulfan or melphalan is coming. So we are mentally prepared that the mucositis is going to be bad. So we tell them right from the beginning how to really take care of the oral cavity. And certain times we ourselves are aware, supposing just a it's a aplastic anemia, fully matched, and we know we need to give just fludarabine cyclophosphamide. We know that mucositis is not really going to be a very bothersome issue in that case. So it is more for the healthcare team to be aware and then appropriately counsel so that when the bad mucositis comes, if the patient and their family members are already prepared, so they take it much more, scientifically, and I would say more better rather than feeling that something has struck as a bolt from the blue. So yes, diseases definitely. Now that's an important question. So anybody who's been previously exposed, say, so we have got two kinds of patients who we take up for transplant. So we can take up a thalassaemic child, a thalassaemic who's never had any chemotherapy in his lifetime, an aplastic anemia who's never had any chemotherapy. So newly diagnosed aplastic, he's just taken a few blood transfusions, and we are lucky to find a quick donor. So that is one of the smoothest transplant that we'll see. On the other hand, we can have a relapse refractory, a kid who has been through uh, ALL, then the ALL relapse, then he had one relapse treatment, a second relapse treatment. So by the time he's already come to us for transplant, he's at multiple very intensive chemotherapies. So there the mucosa is previously damaged. And on top of that, now we are going to be giving a myeloablative because in such a kid, we'll not be able to give a reduced intensity conditioning. We'll be giving a myeloablative conditioning. So yes, those are the diseases. So malignancies is those places. Then there is a disease known as a Fanconi's anemia. Now Fanconi anemia inherently has problems with the mucosa. So in those, when we take up for people for transplants with Fanconi anemia, we sometimes land up with a very bad mucositis. So yes, there are certain diseases in which we are more ready than others.
Thank you so much. Thank you so much. I think that was very clear. Next, can we go ahead? Yes, I think this question is to Ms. Meeta. How can we minimize the risk or severity? Are there any preventive measures? Like how do we maintain even oral hygiene? I think that was one of the questions. Or are there any other measures to minimize the risk or severity?
Yeah. Thank you so much. Actually, before we start the transplant, nurses should be able to do the risk assessment. Very, very important.
Okay.
And that helps the nurses to get the unit ready for the logistics, drugs, surveillance culture, and intercollaborative team members we should be talking to. How should get their help to help out the patient. That's very important. And second thing, we need to empower patient, as I was already telling, with the knowledge that this is a grade of mucositis we are expecting. In your case, it could be grade 3 or grade 4. Pain will be highly intensified. right? Or maybe you won't be able to take food for 7 or 10 days like that. And then, gradually as the neutrophil comes up, the recovery will take place. All this information, it helps because patient won't be able to talk, won't be able to socialize. So all these things we need to inform patients beforehand itself. So that helps, the patient to recognize the symptom early and also helps in self-care. That's very important. So as a nurse, what we should do, for first and foremost thing, we should assess the oral health of the patient. That's important. There could be some infections or like dental needs some corrections. That has to be ruled out. We should encourage twice brushing at least. That's very important. And then that should be fluoride-based paste and soft bristle, which should be that a toothbrush should be frequently changed.
Right.
That's one important thing. And also encourage oral rinses, that is bland rinses with saline gargle, that is half teaspoon of salt with your cold or warm. It could be the water, 250 ml, or sometimes later on when there is ulceration has already happened or the the secretion becomes viscous or sticky. In that case, soda bicam also can be used, or maybe mixture of saline and the soda bicam also can be used. That keeps the mouth clean, moist, and it reduces the bacterial colonization. That's very important. And at the same time, it is gives comfort to the patient. That's very important. Then also we should ask patient to have regular sitz bath. That we start this practice before the transplant happens. That is also another port of entry. And usually patient develops perianal breakdown, so that they should have it at least 2 to 3 times in a day. Very important. We have to improve the nutritional status, nutritional hydration of the patient before the transplant starts. And also carefully, as sir was already talking, careful selection of the protocol. They have to balance among many parameters like how aggressive is the disease, like GVL effect, maybe toxicity of the drugs, and the tolerability of the patient. That's very important. And they got to select the protocol, what should be done. But thankfully and very thoughtfully, the trend is coming down. It is switched from the very, very toxic preparative regime to the now less toxic regime, so that this sepsis as well as the mucositis has come down gratefully. Most importantly, what nurses practice, like as we are going to give the melphalan, we do give the cryotherapy, that is ice sheet therapy. To add the value, we have now made it flavored. Usually it used to be plain ice cubes. Now we have making it flavored so the patient likes it. Sometimes they like to swallow it. Sometimes they spit it out, but they have to hold it inside the mouth. And we use this therapy because if the infusion is very shorter period, because as you know, 30 to 45 minutes it has to finish. And the half-life of the drug should be also very short. In that case only it is beneficial. So this cryotherapy is used. 10 minutes early we start before the infusion. It goes on throughout the infusion time. And then 10 minutes post-infusion it remains, so that it keeps the mouth cool. There's a vasoconstriction. There's the influx of the drug is being prevented. And cooling also, prevents damages of the tissue. That's very important. And then other than that, so I already mentioned the palifarmin. We have seen that is keratinocyte growth factor. It is not marketed in India and very expensive. And that has shown a lot of benefit against the grade 3 and grade 4 mucositis. Gafazole, sir, I think nowadays it is not being recommended. Initially, it showed some benefit. Now it is no more recommended by ONS guidelines. And GCSF, in case of mucositis and severe infection, early GCSF is being it starts. And in case of haplotransplant, D+5 itself, the GCSF is given for boosting the neutrophil engraftment. That is very important. And other than that, I think these are the proactively we should be working as a background work before the transplant starts.
Absolutely. Thank you so much. And just before we move on to the next question, on a lighter note, even after 10 years of transplant, the ice popsicles still work as a therapy for me. Absolutely. And I think we still enjoy the ice popsicles in spite of 10 years into transplant. So that's something that's, I think, going to be for a lifetime. Yes, I think we can move ahead.
Thank you.
Yeah, so this question is to Dr. Shruti. If mucositis occurs, what is the treatment plan? And are there any specific drugs or say specific mouthwashes that I think, just to reiterate the point that was mentioned earlier?
Yeah. So I think first of all, I would like to again thank Meeta because she's mentioned most of the points. But a mucositis, once it sets in and patient has already had mouth ulcers, the main aim would be to maintain the hydration and nutrition, because with oral ulcers, especially with smaller children, they would not like to eat. So it is important to predict that this is going to happen and, put them on an NG tube for a mild mucositis, we can put it and, continue with the nutrition part. As Dr. Sanjeevan said, we can switch to TPN and have a very low threshold so that the nutrition does not suffer further. Very important part is pain control, because mucositis can leave a very, can lead to a poor quality of life and can, just leave a bad, memory of the transplant. So adequate pain control, whether you want to try topical or, a fentanyl patch or IV morphine. At our unit, we have a very low threshold of starting IV fentanyl so that the patient remains comfortable while, the patient is in the BMT unit. But local analgesics, sometimes when we give them these sprays like Lox and all, they cause this tingling kind of or a burning kind of a sensation. So personally, I find it very difficult to use it for smaller children. Hence, we kind of use it more with IV fentanyl or a patch, basically. The one very important, part of this would be oral decontamination, because once you have these ulcers, and as mentioned by one of my co-panelists, that there could be a bad breath because of a secondary infection in those mucosal ulcers, right? So that's why these repeated oral hygiene swishes, or just for a smaller child, just dip that a soft swab in a saline or a soda bicarb and just clean the oral cavity nicely, so that the children or patients do not get a secondary infection or don't go into septicemia from that site of mucositis, would be an important thing. As well as, these commercial mouthwashes are concerned, we don't use them in our unit. We use our basic normal saline or soda bicarb. But chlorhexidine mouthwashes can be used, but that they would cause this burning sensation, so not really preferred. But as Meeta said, if we can prevent it by expecting what hydration to give, using our favorite popsicles or whatever ways, then that's the best way out. Once mucositis has settled in, I think supportive care is what we can do.
Sure. So excellent. And I just have an added question on this, Dr. Shruti, for you. I think there are some misconceptions that people have about applying ghee, applying coconut oil, and all of that, to ease the. So, so what is your take on that in terms of how?
So when we look at the initial stage, as mentioned by my colleagues, that there could be dryness of the mucosa, right? So ghee and these oil, they can be applied outside if there are dryness of lips or something, but not really inside the mucosa. We've come across some trials which said honey and olive oil and stuff like that, right? So honey was one thing which, when I was reading, that there are some reviews that say honey can be used, but in our setup, I would be worried about the purity and will that become a source of infection. So that's why we stay away from such practices. As far as oil or ghee or a Vaseline lip jelly, that is only when you have some cracked lips or just the outer part of the mouth, then that's it. Nothing, not more than that.
But ideally, it's just good to stay away from that till the entire neutropenia phase is over and kind of out of it. Sure. Okay, let's go ahead. Thank you so much, Dr. Shruti. Yeah, so Dr. Sanjeevan again, what can be done to reduce the pain associated with this? I think you spoke about this, but I think apart from the mouthwashes or anything, is there any other treatment, that you just mentioned and you want to reiterate it?
I will reiterate what Dr. Shruti just mentioned. Pain relief, it's a very important part of mucositis. We know it's a transient thing. It's going to be 10 days, not even 10 days. It starts maybe day -1, day 0, and by day 10, 11, 12, it's all over. So sometimes it may start at day 3, day 4, and may be over by day 10. So between 1 week to 10 days is average, and at max, it can go on till, let's say, 12 days. So if we know right from beginning that it's a 12-day issue, the most important part of any transplant physician is, why should our patient suffer pain even for 1 day when we can help it? So I would say nothing, we shouldn't be asking what can be done to reduce pain. If there is pain, the pain should be relieved. It is as simple as that. Whatever is relieving the pain. So whether it's a small child or it's a gentleman of 65, right now in my transplant unit, I've got a 69-year-old gentleman who's taking a myeloma transplant. I think he's going to be discharged. We didn't allow him to be in pain for even a day, because whether I have to use however doses of morphine, fentanyl, pethidine, whatever one has to use, we have to make sure that he is not in pain. So to reduce pain, there are no dearth of painkillers available besides the topical things. Yes, that have been mentioned. We'll start the topical therapy right from beginning. But if the pain occurs, we have to give adequate pain control.
Right.
So there is no compromise in pain.
Great. Thank you so much. Yeah, we can move on to the next question. Yeah, I think this is to Miss Suman. And I think this must be a question which must be as regular as any other question in the BMT space. What kind of food should be avoided and what should be preferred during the phase of mucositis?
Yes, thank you. Sir, managing diet is very important to reduce irritation and support healing of mucosa. So my next slide is, so avoid spicy food, which can irritate sores and increase discomfort. Nirav, please, next slide, please. So avoid acidic food and beverages such as citrus food and vinegar, which can worsen irritation. Hard, crunchy, and rough texture food that can be avoided to prevent damage to the sensitive tissues. Salty food causes burning sensation, so that's and aggravate the existing sores, so that should be avoided. Too hot and too cold drinks can be increase in inflammation and pain, so it should be avoided. Alcohol and tobacco can irritate, that can be hidden in recovery and it should be avoided. Dry food can be scratch and irritate the mouth, healing. So and it makes discomfort for the mucosal. So they should be focused on the soft. Next slide, please. They should be focused on the soft, moist, and bland food that are easy to swallow, and like yogurt, pudding, they can have, and consider the hydration, which and non-irritating foods, and they can consult of consulting doctors or dietitian for their daily food activity food and advice during the treatment. So they can have which can be easy for them and to avoid the bloating or the that discomfort will be not there. Thank you.
Wow, excellent. Excellent point. I think you mentioned about small meals and frequently, I think, dividing it in the day. Yes, thank you so much. Yeah. Next question. Yeah, this is to Miss Meeta again. How do we ensure, in spite of the pain associated with mucositis, enough nutrition is given to the patient? And what is, like it's called parenteral nutrition, and when is it considered?
Thank you. Suman has already told about the oral nutrition. Only one thing I just wanted to add, it must be hygienic, because mucositis usually occurs during the when patient is profoundly neutropenic. So we try to maintain low bacterial diet. It should be well cooked, hygienic, and freshly cooked. That's very important. We should provide to the patient.
Sure.
And usually, as I said, nutritional assessment is very, very important. Very, very important before we start the transplant. And it is a very stressful and hypermetabolic state. It's a catabolic phase, like patient breaks down. That happens. And nutrition is imperative to prevent the further breakdown, complications, as well as your this poor outcome. That has to be prevented. So in that case, we do go by certain, there are scoring systems are there. We do that nutritional screening by that way. And, in that body weight, patient's BMI, then those things we got to monitor regularly. But when patient develops mucositis, by grade 1, grade 2, still patient do take food. But when the things becomes very, like when he cannot swallow, that's very important. Yes, loss has become more than 10%, or intake has gone down, less than 50% or 60% food intake. So in such case, for the children, usually they like to prefer to the enteral feeding. And as long as child can tolerate, enteral feeding is being given. But for the adult, usually the parenteral feeding is being administration is being considered in that case. Also, we do consider certain biochemical marker like albumin. If it is less than 3, also one has to quickly they switch to the parenteral nutrition I've seen. And there could be some episode of GI bleeding, such case also, and the diarrhea, painful abdominal pain, repeated vomiting, nausea. So we can't give oral feeding anymore. So in such cases, parenteral nutrition is being considered. So parenteral nutrition is nothing but it is the intravenous administration of nutrition, that is of nitrogen, calories, and other nutrients in adequate amount, outside of the GI tract, it is being given. But it comes with a lot of nursing responsibility. Before we start, the physician should refer to the clinical nutritionist for the evaluation. That's one thing. So the calorie, it is actually customized according to the patient's need. Every patient's need is not the same. So accordingly, it has to be evaluated. And then what kind of parenteral nutrition has to be instituted, that is the decision is taken. But it comes with a lot of responsibility. Nurses have to evaluate the central line. It is given through the central line. Aseptic practices has to go on. That's very important. And then a lot of electrolyte status they have to see. Glycemic status has to be, time to time it has to be checked. These other things has to be checked, very important. Most importantly, it goes on 24 hours, like patient's ambulation and independence is being lost. So we should make sure that with the mobile stand, patient is made to walk with the therapy on. So that's one of the advantageous point, which should encourage for the patient and nurses to do so. That's important. And also patient has that agony in their mind, or patient relative has agony that my child is not eating or I'm not able to eat food for past 7 days. So we got to tell them that this is a nutritional bag which is being hanging. It is, taking care of nutrition. That has to be informed to the patient and patient family member. Very important. And that is what I think we should do for the parenteral nutrition. And once patient starts taking food later on, as the neutrophil recovers and the ulcer starts healing, and patient's intake becomes more than 50%, and then we switch back to the liquid to the semi-solid to the solid. We go back to the normal nutrition.
Excellent. That was really well covered. Thank you, Ms. Meeta. Yeah, we can go ahead. Yeah, can we go to the next question, please? Yeah, thank you. This to Dr. Shruti. Is mucositis associated with increased risk of infection? If yes, how can we avoid it?
Thank you again, Neerath. First of all, I must say that, with what Ms. Suman and Ms. Meeta are saying, we must understand that it's the nurses who are behind a successful BMT program, and without them, we won't be able to get through, right? So thank you so much, Meeta, for doing that. And I think Dr. Sanjeevan had shown a very nice picture in which, you had a mucositis and lots of bacteria underneath. So that just explains what I have to say, that yes, if there is a severe mucositis, it may lead to an increased risk of infection and sepsis and septicemia. And as the grade of mucositis increases, the chances of a patient going into sepsis is also proportionately high. So the two reasons, when somebody develops mucositis, why there is a risk is, one is the nutrition gets hampered. That's why all the TPN and nutrition that Ms. Meeta was just talking about is so important, because a malnourished patient is always is immunocompromised and is at high risk of infection. Second is that break in mucosal barrier from which the bacteria can translocate. Whether the mucositis is in the mouth or in the gut, the bacteria can translocate, go into the blood and cause sepsis and septicemia, and can get, can go to any other organ and cause infection over there, right? Second, how can we avoid it? Avoidance is by all means is by good nursing care, right? When we are talking of nutrition care, that is one part of infection prevention. Mobilization, as Meeta just said, looking after the abraded mucosa by good oral care, good oral hygiene, and then some prophylactic, like some of the patients who are on undergoing myeloablative transplant, they go on to prophylactic antifungals or drugs post-transplant, so that they do not get these fungal infections and develop these sepsis, right? So these are certain things that can be done. Most importantly, a good nursing care and maintaining good hygiene overall would be the best way to prevent this risk of infection in a patient with mucositis. Thank you.
Thank you so much, Dr. Shruti. On the same note, I think It's also time that we recognize the other caregivers who are the family members in the unit who actually make this happen for the patient. I think it's so amazing to bring in warm food every single day, 4 times, 5 times a day for 21 days in a row when they're in the unit. So I think it's absolutely commendable and huge gratitude to everybody out there. Thank you. Yeah, we can move on to the next question, please. Yeah, so easy one for you, Dr. Sanjeevan. I think is loose stool syndrome.
Definitely.
Okay.
So, but at the same time, we should lose tool in a transplant unit is something which gives the biggest nightmare to the transplant team, whether it is the doctor or the nurse, So yes, it could be. So I'll be very happy if it is only because of mucositis and not something else. But yes, so it's something a loose tool is assessed very scientifically in a transplant unit. What all it can be. Is it because of one of those bad things which we are all fearing about? Is it because of that? Some very dreadful infection. Is it a bacterial sepsis, or if it is just a plain mucositis? So yes, if definitely mucositis can cause loose stool. So that of course needs to be assessed. Yes.
Absolutely. Thank you so much, sir. I don't know if we have any other questions left, but if we are, I think we can cover it. Else, I think
There are so.
There are 3 more questions.
Okay,
if we
okay,
can
let's go ahead
quickly
quickly.
do
I
them
think we're
in
short of
5
time,
minutes.
but I think we can go through it quickly. Yeah, do we have time for those?
Yes, sure.
Yes, sir. Niro, please quickly move to the next slide.
Yeah, I think this is an important one, Dr. Shruti. In terms of the treatment schedule or engraftment or any other question, I think, does it affect the schedule of engraftment, if this happens?
Yeah, thank you, Neeraj. So there are certain things which do get affected by mucositis. That is, as we just discussed, increased risk of infection. It can cause pain and impaired function. There is increased need of supportive care, increased hospitalization adds to the cost. So these are one part of, direct effects of mucositis. Secondly, there is this because of the altered mucosa and altered gut microbiome, it may have some role to play in chronic, acute or chronic GVHD, right? So somebody who has a bad mucositis may have a higher risk of GVHD. As far as engraftment is concerned, it does not get affected directly, but if somebody goes into sepsis and there are inflammatory response, then yes, it may affect. The other thing is about the schedule, right? So somebody who develops a bad mucositis, we may avoid giving, what we call as a methotrexate dose, which is on day 11, right? So that is a physician decision at that point of time, how bad, the mucositis is, or what are the chances of getting, what risk of getting GVHD based on all the parameters at that point of time. So I would just like to say that mucositis does have a effect on the overall, outcome because of various factors. And, if the nursing care and hydration and everything can be done upfront and try to avoid. I can completely understand it's not completely avoidable, but wherever and however it can be, we must try, give it our best.
Oh, absolutely. And I think it's also for the patients and their families to understand that you are working on such a thin line of balance between checks and balances, engraftment, neutropenia, mucositis. So, there is a cause of delay should not be a cause of worry. And I think it's all manageable, that you're in safe hands. So I think that assurance is so important for the family and the members. So yes, thank you so much for bringing that up. Yeah, next question. Any long-term complications, Ms. Meeta, that we can associate apart from GVHD that I think Dr. Shruti mentioned? Anything else that we have to look out for post-BMT in terms of long-term complications?
Yeah, actually, this mucositis is usually it is self-limiting
and
transient, as it already mentioned. As a neutrophil engraftment takes place, ulcer heals, the pain reduces. There is demand for analgesia, total parenteral nutrition, antimicrobial therapy reduces, nutrition reestablishes. Patient starts communicating. It becomes very easy for them. So, but I've seen certain drugs like melphalan, it can have long-lasting GI toxicities, could be even up to 1 month to 45 days. I've seen patient having, very frequent diarrhea. That's one thing. Or as Dr. Shruti was already mentioning, like mucositis, usually, it happens when there is a profound neutropenia as well as central line in place and high chances of sepsis. And sepsis can make the things more complicated and worse. And along with that, the patient, there is a delayed engraftment, and if patient fails to engraft, situation could be, fatal. That is one thing. Second thing, altered microbiome, which can be initiated by mucositis, that also can establish the GVHD. And next thing, dose limiting toxicity, as already she was mentioning. And most important thing, I must say that cost burden may go high. Hospitalization might, become, it can get extended by another 4-5 days. And lastly, a patient would bear a traumatic memory. Though it happens in varying degree, somebody may experience grade 1, somebody may experience grade 4, but that memory, it is long lasting memory. It's like, something fish bone, which was embedded inside her mucosa, and they can explain much better than us, and we can only just feel and can do something for them. But that memory, it is long lasting with them.
Oh, absolutely. Thank you so much. Yeah. Next question, please. Higher doses result in higher chance of mucositis. Can we reduce the dose of medication? Dr. Colonel Sanjeevan, how do you respond to that?
Just typing out one answer. There was another question. I think in response to what Dr. Shruti just mentioned, that why do you skip the day 11 methotrexate? So the answer to that was, of course, it is not that skipping, it's a balance which we have to see, because any methotrexate is one of the drugs which can further enhance the mucositis. So if the risk of GVHD is very low, we may even just think, okay, right now it's the mucositis is a bigger issue, not the when the GVHD comes, we'll tackle it as it comes. So that is one. And similar question is this one. Higher doses resulted higher, but then the idea here is not to avoid mucositis. Person has not come to the PMT unit to get his mucositis treated. He has come to get his cancer treated. So if his cancer requires or his condition requires, he is a thalassemic child, he's come to get rid of thalassemia. If thalassemia can't be gotten rid with low doses, it requires very high doses. So that is the most important thing that we need to see. It is mucositis is a side effect of a therapy which we give, but we can never take our attention off the main reason why any patient has approached us. A person with lymphoma or myeloma comes to get rid of his lymphoma or myeloma, not to get his, mucositis. So mucositis can be addressed, but not at the cost of reducing the dose of medication so that mucositis doesn't come. That is not the approach.
Absolutely. Absolutely. Great. Thank you so much. And I think one of the things as a takeaway for a patient here is, as much as possible, please support the nursing staff by ensuring that you take in the nutrition, even though with a little pain, so that at least the nutrition is maintained till the time that you completely can't bear it. So yeah, so thank you so much for all the panelists here. Very enlightening, and I'm sure it'll help a lot of patients. Thank you.
Thank you so much.
Nice to see you, Venkatesh.
Thank you all.
Hi,
Thank you.
Venkatesh. You're still in hospital, huh?
Me, sir?
No. I can see Venkatesh. Me and Venkatesh. He's muted. Although he's muted, I can't hear him.
Yeah, hi. Hi, Sanjeevan.
Hi.
It was such a
Hi.
pleasure. Hi, Dr. Shruti and Dr.
Hello.
Great initiative, this patient support group.
Sanjeev. Right. Thank you so much, everyone, for bringing out uh, the topic so beautifully and yet so simplistically. Uh, Basically, mucositis is a part and parcel of a transplant treatment, and like Dr. Sanjeevan wonderfully put, that we have to achieve a balance between reducing suffering and at the same time making sure that the disease itself is taken care of. And uh, that is the entire emphasis when we start our patient selection, conditioning regimen selection. Thank you, Dr. Sanjeevan, for outlining it through various examples that you gave to your practice. I want to thank Dr. Silky and Neeraj for curating the questions that come from the patients. Analysts can be put to test Now, I really thank Dr. Shruti for the time and the inputs and the insights that she shared as a BMT physician. I thank both the nurses, without whom our knowledge is very superficial, because on the ground they are the ones who give us the inputs, and we have to we rely on their eyes and ears to make sure that our patients are comfortable all throughout the transplant process. And I also want to thank Dr. Revati for bringing out this topic, which was so essential to be addressed. Last but not the least, I thank all the patient support group attendees and all the representatives of patient support group. Dr. Nita Menon ma'am is here. Neeraj has been at the forefront.
It's very
This leading into a good success.
Mucositis.
Thank you so much. I
Mucositis
learned
is,
a lot.
yeah, it's a big issue. Thank you so much.
All right. And so now I also want to announce that the next meeting will happen on the 12th of July, and the topic will soon be circulated. Watch this space. Thank you very much. I declare this meeting closed.
Thank you all.
Thank you, sir.
Thank you all.
Everybody.
Thank you, Nirav. Thank you, Silky ma'am. Thank you, Shruti ma'am.
Thanks.
Bye, ma'am.
Bye-bye.
Bye, Rashmi.
Bye, ma'am.